Good afternoon, ladies and gentlemen. My name is Dr. Asavri Sawant, and it's my utmost privilege to welcome you to the World Cancer Day live panel discussion on conquering breast cancer, early detection for better protection, on behalf of Voice of Healthcare, powered by AstraZeneca. Please let me give a short brief about our main objective behind today's panel discussion, which is to generate awareness regarding early detection of cancer. As we all are aware, early identification is critical to elevating outcomes in the treatment of breast cancer. Every year, 4th of February is marked as the World Cancer Awareness Day. It is a global uniting initiative led by the Union for International Cancer Control, and it is a day to raise awareness about cancer and encourage its early detection, prevention, and treatment. So, this World Cancer Day, we recognize the power of knowledge. This year's theme is Close the Gap. The first year of this campaign is all about understanding and recognizing the inequities in cancer care around the globe. For today's talk, Voice of Healthcare brings leading minds and experts together. Please let me welcome our esteemed speakers, Dr. Vijay Agrawal, Lead and Senior Consultant, Medical Oncology and Hematology at Esther CMI. Dr. Agrawal will also be moderating today's talk. Welcome, sir. Let me
Thank you very
introduce
much.
Dr. Shalini Singh, Director, National Institute of Cancer Prevention and Research. Welcome, ma'am. Next, we have Dr. Geeta Manjunath, founder and Chief Executive Officer of Niramay Health Analytics. Welcome, ma'am.
Thank you.
Next, please let me welcome Ms. Nirja Malik, author, I Inspire, global cancer counselor, an inspirational speaker, and cancer conqueror herself. Welcome, ma'am.
Thank you, sir.
Next, please let me welcome Dr. Sneha Bhuyar. She'll be there with us shortly. She's the chairperson of Breast Cancer Committee of FOGSI and managing director of Sukrita Hospital. Next, I'd like to welcome Dr. Vani Parmar, professor of surgical oncology at Tata Memorial Center for Advanced um, Tata Memorial Center for Advanced Treatment Research Education in Cancer. Welcome, ma'am.
Thank
Please
you.
let me welcome Ms. Devika Bhojwani, Vice President, Women's Cancer Initiative by Tata Memorial Hospital. Welcome, ma'am. It is said that no milestone is impossible when we aim for it together. So, without further ado, let's begin today's session. Over to you, Dr. Agarwal, now.
Thank you, Dr. Ashavari. Thank you for having me here. It is indeed a pleasure to be amongst such esteemed panelists. So thank you very much for all being here. I think we'll have a discussion about. Oh, can you hear me?
Yes.
Uh, it is indeed a pleasure for me to be here among such esteemed panelists. I think I'm going to start off with talking about breast cancer screening and prevention. So, Dr. Vani, can you just tell us why is it so important that we focus on breast cancer screening and early diagnosis?
First of all, let me wish everyone a good afternoon and thank you very much for having brought this topic up as the first topic of discussion for the year. A very important topic. As far as breast cancer is concerned, I would probably slightly disagree upon the fact that screening is important, but yes, early detection is a very crucial and very important aspect of breast cancer management. Um, Cancer itself creates a kind of a fear in the mind of women, and of course, it's also seen to happen in men nowadays. So it's not that only women are at risk of getting breast cancer, but what is really important here is that cancer itself is not really something that one needs to fear. Earlier a cancer is detected, cancer can actually be cured, and a long-term survival is really seen. As far as early detection is concerned, if they are picked up early in the first stage, the survival can be as high as 95 to 98%. But unfortunately, when it is not brought out and not treated early, it can, in cases of advanced or stage 4 cancers, can lead to only less than 5% survival. So what we really need to aim is to detect the cancer early, treat it early, so that not only is the surgical outcomes much better, but also the overall outcome of cancer treatment.
Thank you. Dr. Vani, do you see a difference in terms of the kind of patients who present to you, or what proportion of them are early stage as opposed to advanced stages? And in your experience, what has been the outcomes?
To be very frank, over the past few years that I have been in this field, I have seen a radical change from what was there, say, 2 decades back to now. We were earlier seeing much more of larger tumors. As far as stage difference or stage migration is concerned, there is a gradual move towards the stage 2 or the early cancers, which are much more common now in India. So, now let's talk about in India only. I don't want to take a comparison from what we see in the West. In India, we don't have screening as a standard procedure being followed as a national program. And what we see really is the clinical presentation. And within them, I think because of increasing awareness over the period of time, we've seen a gradual reduction in the size of tumors that are presenting. And that means that we are moving with the stage uh,
Thank you.
three cancers or the large tumors coming down now, and much more of stage 2 cancers or the smaller tumors. Now, this gradual change which has been seen is it has been observed over a period of years. It's not that it's an overnight change. Again, I think what we see as locally advanced tumors, these used to be nearly about 60 to 70%. They've come down to now to about 50%. The early breast cancers used to be only 20% earlier, have now come up to about 45 to 50% of them being early cancers. However, there has been surprisingly the advanced cancers which have already spread. Now, these cancers seem to be remaining stable and have not been not much of a change, and about 5 to 10% of cancers still present, already disseminated, and therefore are very advanced for treatment.
So, clearly, Dr. Vani, early diagnosis is probably paramount in our fight against breast cancer. And I think the earlier we can diagnose, the more likelihood of achieving a cure. So,
Absolutely.
Dr. Shalini, can you highlight on what kind of breast cancer screenings are available and what would be feasible in a society like ours? We can't hear you, Dr. Shalini. I think you may be on mute. No, we still can't hear you. No, I can't hear you. Can anyone else hear Dr. Shalini?
No.
No, I think her device the volume itself is low.
No, not her.
Dr. Shalini, I'll come back to you while we get the backend team to sort out the IT part. So, but we come back to Dr. Shalini with regards to the breast cancer screening methodologies. But clearly, cell breast examination is probably one of the easiest to do and the cheapest screening methodology. Ms. Devika, can you highlight on the role of cell breast examination and how we can incorporate that in our practice or in our society?
Well, thank you so much for having me on the show. It's wonderful on World Cancer Day that we're all getting together, focusing on something that is affecting so many women all over the world. Breast self-examination is a wonderful tool, but actually has not been proven to reduce mortality from breast cancer in a large study. However, most experts agree that breast self-examination is likely to be useful in countries like India and other developing countries. Now, breast self-examination is also a very good method to improve and create awareness about breast cancer in populations, especially including women. Women are likely to approach the healthcare system much earlier because they will get familiar with their breast. They will pick up a cancer or any abnormality much earlier. Unfortunately, in countries like India, women are coming at much later stages, and a self breast examination, once you become aware of your own breast, of your normal breast, any abnormality will be picked up much earlier. We found that We've done many camps where we've had women come in and understand just what a normal breast feels like. We did these in colleges. We invited all the women to attend, and believe it or not, some of the boys from the colleges would also request us, can we come in and understand this so that we can actually help our mothers, our sisters, the women in our family to learn something as simple as this. It's so heartwarming. This is something that is a point that we all need to understand. Just the women don't need to be addressed about it. The men
Hello.
who care for their women are just as important. Now, the one important thing about breast self examination is it can be taught by a not a fully skilled person, it can be a health worker. It's cost effective, doesn't cost anything. We encourage young
William
girls.
Stream Yard Support. Have a great show.
Sorry, can you hear me?
Yes, yes,
Uh,
yes.
so we actually are hoping that young girls, once they reach puberty, will be taught how to do a self-breast examination. Maybe even in schools and in colleges, it will be a wonderful program to start at the time of the menstrual cycle, and maybe women post menopause after their 50s should be taught how to do this. It's something that doesn't cost anything and can bring you results. It can make awareness much wider than it actually is.
So we do, I think we
So,
do agree that at some level, self-breast examination probably has a very important role to play in our society because of the
Dr.
ease of.
Vijay, can I add to your question there that you placed to Devika?
Sure.
So as far as the breast self-examination is concerned, I'm going to give in the clinical, the clinician aspect of breast self-examination, clinical breast examination, and mammography for screening. Now, as far as the breast self-examination is concerned, it is definitely a very good awareness increasing tool, and like Devika has pointed out, should be started very early, especially school girls, and if they know how to examine themselves, they will be more breast aware. But then, if you look at the actual evidence in the society on what is the level of evidence for breast self examination having served as a very good screening tool. And when we're talking about screening, we're talking about picking up cancers in ostensibly healthy women who have no symptoms of cancer. And these are women who are walking around doing day to day life and not having thought of cancer as well. Now, in such situations, breast self examination actually has failed to be a very good screening tool, more because the anxiety that it creates. But clinical breast examination has been tested in a randomized setting even in India and in Tata Memorial as well, and has shown to be a very effective tool for downsizing the tumor, that means picking up tumors much earlier. So, clinical breast examination as a tool probably works much better than breast self examination. And of course, mammography in India itself is not a doable examination. For one thing, because it cannot be applied to the masses, it's quite an expensive affair to have this as a program. And second point that I want to bring in is that a mammography has not really served as a very good screening tool for below 50 years women. And women in India, majority, 80% of them tend to be below 50 years of age. So mammography as a screening tool for healthy women is not a very good tool, but it still remains potentially an opportunistic screening method for people, for women who are symptomatic or have, have some doubts on self-breast examination of having a lump or presenting with a lump.
Vijay, can you hear me now?
Yes, yes, we can hear you. So, Dr. Shalini, can you pitch in? I mean, obviously, there was Dr. Vani has brought up some good points in terms of the role of mammography in comparison to the self breast examination or clinical breast examination. So, can you highlight on the way what are the various screening methodologies that are available, and which one would be best fit for our society?
Yeah.
Dr.
So,
Shalini.
what has been, I missed the little part which is being discussed. But what I understand is that the government is promoting the clinical breast examination as a screening tool in our situation, because as Dr. Vani also pointed out, that mammography is not widely available, not even in countries apart from US and very high income countries. So, clinical breast examination currently is being provided by the government sector for women age 30 to 65 years every 5 years. And so far, that seems to be the feasible option. If I heard correctly, I mean, we've also read that clinical breast examination is by far the most widely used screening method for breast cancer. And a study which was done in Mumbai in 20 clusters, where in 10 clusters they had done the clinical breast examination through the frontline healthcare workers at a interval of 2 years versus those who were taught self-breast examination. Clearly, clinical breast examination had brought down the stage of cancer in women more than 50 years of age, and also the mortality. So I think as if larger number of people are actually subjected to clinical breast examination, we should be seeing better results.
Yeah, absolutely, absolutely, Dr. Shalini. I mean, clearly we know that self-breast examination may not be foul-proof, and more than the pickup rate, it increases awareness. But clinical breast examination is probably the way to go for our society because mammography is not that easily accessible and available for the vast majority of our women who are in the rural setup. But clearly, and the other thing is that obviously it doesn't have to be a doctor who needs to do a clinical breast examination. It could be anyone who's properly trained to do so. Dr. Shani, what do you think about the frequency? Do you think the 5 years is going to be okay, or do you think we need to do it more frequently than that? Given that in the high-income countries they do mammography every 2 years. Do you think we need to bring our clinical breast examination lines with that, or we feel 5 years is good enough?
So I think people with higher risk of breast cancer, we know what are the risk factors for breast cancer, and and also what are the protective factors for breast cancer. So, if a person is at risk of breast cancer, definitely they must address those risk factors apart from getting themselves screened early. Self breast examination should also be, I think, encouraged so that every month they are doing it and they know what is the feel of their breast so that they're aware of any abnormality which crops in and they can visit the doctor early. But at least 5 years is something which has been proposed by the government. Right now, that is also seems to be a very difficult thing to be given to 100% women. So I think we need to encourage people to go in for self breast examination themselves, and as possible, they must get a clinical breast examination.
So I think it's fair to presume that the clinical breast examination once in 5 years and more frequently cell breast examination would help identify, would be a good screening methodology for our country. And of course, in the urban situation where people have access to mammography, you could look at mammography once every couple of years. Dr. Sneha, obviously, being the chief of Foxy, the gynecologists themselves are usually the frontline people whom the patients present to when they develop a breast lump or any abnormality in the breast. Do you think in our society gynecologists are adequately trained or have the skill set to deal with breast disorders? And what do you feel about the approach of patients to gynecologists as the first point of contact?
Yes, thank you, Dr. Vijay, for that question. A very good afternoon to everyone. In fact, I would just go a little back and say that by virtue of our practice, we are well versed, rather, we should be well versed with whatever breast problems we face right from early puberty, whether it is a premature therapy or delayed therapy, right from that age to the reproductive age group, and then breastfeeding and all those problems, right up to menopausal and postmenopausal problems, we tackle these situations. But in spite of all this, our gynecologists are not very comfortable, at least till recent few past years, they were not very well versed with breast examination. The moment they had some problems with the breast, they used to refer the patient to surgery. So even for breastfeeding, the mastitis and breast abscess, all these So what Foxy has done, Foxy has started this breast committee, and the committee has the aims and objectives of breastfeeding promotion, tackling the benign breast diseases, and making awareness, screening, and early diagnosis of breast cancer, and of course, referring timely to the appropriate person, that is the surgeon, breast surgeon, oncosurgeon, whosoever it may be. So, our field is, we are the first point of contact, as you have rightly mentioned in the question itself. The women come to us, gynecologist and obstetrician, for whatever their problems they're having with their breast. So, in fact, even if it is not breast problem, we have to utilize this window of opportunity. And as a breast committee chairperson, after every webinar, may it be an educational session or a awareness session, we are just trying to sensitize our Foxians or obstetrician friends that you make it a habit to examine the breast of each and every woman who comes to you for whatever their problems. And of course, you try and identify their risk level. You analyze their risk level. Talk to them. Talk to them about their family history, their medical history. You assess their risk for breast cancer, and of course, you advise them regarding self breast examination. You teach them self breast examination, what is the appropriate time, and then, of course, you perform the clinical breast examination, how they have to report to you, what investigation needs to be done. So, all these things have to be explained to the patient. So, our aim being sensitizing the Foxians for training them, because I don't think even till today our PG curriculum has enough training of the obstetrician gynecologist regarding the breast issues, and that's the very reason we are continuing with the medical education sessions. We are updating their knowledge with newsletters, updates, and all the academic sessions, and of course we are training the paramedics as well. I think training the paramedics, especially the ashas, is going to make a big difference in this, because ashas are very very dedicated workers, and if we really teach them, train them for clinical examination, reaching to the most grassroots level will be possible with the ashas. So I think training the paramedics, and of course making awareness in the general public how their breasts normally should appear at menarche, at reproductive age group, during pregnancy, during lactation, menopausal age group. So what is normal and what is abnormal, how they have to identify the abnormality, and how early they should report to their clinician. I think that should make a difference. And so we gynecologists definitely has a major role as far as early diagnosis or detection of breast cancer is concerned. I
Thank you,
think
Dr.
that should be all from my side.
Thank you, Dr. Sneha. I think rightly put. I mean, gynecologists are some of the busiest doctors around, and most of the time they deal with issues other than the breast. So pointing out or examining the breast is probably a good way to impart information in terms of early diagnosis or making them certainly breast aware, and clearly training the paramedics who can go door to door will certainly help disseminate the education and help identify early breast cancers in a society, particularly, like you said, the people who need it most don't always come to the hospital or come to the gynecologist for a breast examination. So it's a very, very rightly put and very aptly put, Dr. Sneh. So, Dr. Geeta, there obviously we've spoken about cell breast examination or clinical breast examination and mammography a little bit, but obviously things are changing at a rapid pace. So, can you talk to us about some newer technologies that may be available or that Nirma may be involved in or developed to increase the breast screening pickup as well as the speed at which the screening can be done? Dr. Geeta?
Sure. Thank you for that question, Dr. Vijay, and it's a pleasure to be on this panel with the eminent panelists. I completely agree with Dr. Shalini ma'am, Dr. Barney, and also Dr. Sneha about the role of self-breast examination on a more regular basis and clinical breast examination wherever possible, wherever it's being done, so that we can pick up things that were most likely not picked up by self-breast examination. However, I probably differ saying that India needs more, right? Why? Obviously, mammography, as Dr. Mani ma'am mentioned, mammography is not feasible for India because it's not scalable in terms of sort of economics. Probably interpretation also requires radiologists, and radiologists for use of radiologists for screening is not possible for India because we have a number of experts to a number of expert radiologists to number of patients or general women. This is huge, a huge ratio that we can't afford to have mammography for regular screening. As well, she also mentioned about women under 50, right? Who are also getting breast cancer. Actually, the mean age for breast cancer is 10 years younger in India compared to the rest, many countries, other countries. So with this, what can technology do? Is there something else, which can provide the accuracy of mammography at a much lower cost, at a in a scalable fashion, feasible fashion for large scale community screening? And that is what at Miramai, what we worked on for almost 6.5 years now, and happy to say that we have seen extremely promising results for community screening as well as screening in hospitals, diagnostic centers, corporate screenings as well. So here we use artificial intelligence where there is some kind of a smart decision making that a machine can do. It's not in lieu of the doctor. Doctor is always necessary, but to do screening, right? We need to give tools to the health workers, which makes the result less subjective. Because, of course, we talked about clinical risk examination. There are also papers which show how inconsistent the results are, right? When you actually send out health workers to do the clinical risk examination. And then there are papers which say that you actually may think something, there is a lump, and then bring them to the hospital. And again, specialists, maybe gynecologists, redo the tests and there's no lump at all. So there are also false positives and false negatives possible, right? Because of the scale and the skill differences that exist in health workers. So here using AI and not mammography, because mammography does not work on younger women, as Dr. Vani ma'am already mentioned. So we use thermal imaging and AI, we call it thermalytics, where we just measure the temperature variations on the chest using a thermal sensor, analyze automatically to say whether the person is likely to have a breast abnormality, what is the probability that it is actually malignant or like versus benign, and also try to point out the area of malignancy in terms of the quadrant and the clock position, so that a follow-up ultrasound test can ultrasound, or if they want, they can repeat a mammogram, but an ultrasound is sufficient to say whether it's an abscess or it's actually or fibroadenoma, or it actually needs a histopath to confirmation, right? So this test is what technology has enabled us to do. And there are other newer technologies that are emerging, but still in early stages, very early trials of using microwave technology, for example, right? But talking about what I know best in this is thermal imaging and AI. And this has really made screening possible, early diagnosis possible, because a hand examination, let's say self-breast examination, which is definitely the cheapest, we keep telling them also that they have to do monthly examination. That can basically find about 2 to 2.5 centimeters of lesion where you start feeling it's abnormal. Whereas, a technique like this, which is highly sensitive, is able to detect even a 5 under 1 centimeter T1 nodules as well, which is also proven now with additional clinical clinical evaluations with respect to mammography, that it has higher sensitivity, much higher sensitivity in dense breast and younger women as well. So this is something that can is an example of how technology can change the scene, right? By adding scalability, by adding automation, so additional tools in the hands of the health worker, and adding objectivity, non-subjectivity, right? So which is also very, very important, so that we don't have too many false positives and we don't miss too many cancers. That is, don't have too many false negatives as well. So this is what a technology with AI and the right kind of imaging can do. And I think It's not just in India. In many countries which have economic constraints, right, resource constraints, both from an expert standpoint and funding constraints for doing systematic screening programs, should and can adopt these kind of intermediary, automated techniques. Obviously, it has to be after clinical validation, sufficient clinical validation is done. But yes, uh, there is definitely a huge scope for a synergy between technologists and the clinicians to actually come up with newer innovations such as these.
Thank you, Dr. Gita. I mean, clearly automation is the way to go, and all the techniques that were previously been available has been around for a couple of decades, both clinical breast examination as well as mammography. And I think we have to evolve so that, particularly in a country which 1.3 billion people, we need scalability and automation to help reach the right people that we need to. That we need to. But
Yeah,
Ms. Nirja,
Dr.
Ms.
Vijay, just a comment
Yes,
to add. Since we
yes,
are
Dr.
moving systematically, and we talked about the advances in technologies that have come in, where we're looking at screening. Now, as I had already started in the beginning, and I said there is a difference between screening and early detection, and one has to understand and distinguish the two. Let me also bring in a little bit of controversy here, because it's always nice in a discussion to have both viewpoints being discussed and then understood. So as far as the thermography is concerned, there is data enough to say that the sensitivity is just short of mammography. Now that brings in another important point to understand that mammography itself failed in below 50 years of age, for the simple reason that in premenopause is the dense breast. Thermography promised to be a better tool by bringing in, a different aspect of temperature. That is where we're looking at, because vascularity of a cancer has higher, with higher temperatures, would be picked up in a thermoscan. Now, the point here is that the only tool that has been ever tested in a large population as a screening tool is only clinical breast examination. Looking at all the others which have come in, which is breast light, thermoscans, the glove that has been brought in, and all of these tools have been tested in small pockets only, and have not really been tested in a larger population. To promote them actually as a screening tool, I think I will refrain from promoting anything as a screening tool, because screening is a very important endpoint on a national level. When we're talking about increasing awareness, I think everything helps to increase awareness, whether it is thermoscans, it is mammography, whether it is clinical breast examination or breast self examination. Now, that's why a word of caution to say that there is no tool which supersedes the others. And when it comes to detecting cancers, whether AI has been incorporated with thermoscans or not, but thermography per se did not, in our testing at least, did not come up to be a superior tool compared to mammography. And that's where I think I would put in a little bit of caution. And then Dr. Gita, I think you can comment on that,
I
because there is
definitely want to comment on
definitely
that,
things
ma'am.
which,
So,
yeah,
if I may comment on it, thermography is an age-old tool. Thermography has been
correct,
around since 1980s. So it's a 30-year-old,
absolutely.
but we are not talking about that now. We are talking about thermalytics, which is use of AI on thermal images. And we're talking about this test, which has been screening more than 40, or close to 50,000 women today. And we're talking about a tool which is now CE mark, which is talking about a tool which is now starting to be used in UK as well as several other countries in Europe, and starting a trial in India. So in US as well. So what we are talking about is not thermography. I just want to clarify what at least I spoke about is not thermography. But I agree that thermography had sensitivity and specificity issue. That is exactly where technology can play an issue. Thermography is not a technology. Thermography is a method of detecting temperature variation. It's just like X-ray in mammography. Thermography is just temperature. But what I'm talking about, technology, which is AI modules, which analyze these temperature variations, which generate the report, which says whether there is, and this one has 70% higher specificity as well than thermography. So, I mean, we can take this offline as to what are the clinical tests done and how we are compared with thermography. But what I talked about is not thermography, it is thermalytics. Thank you.
Thank you, Dr. Geeta. I think we're going to move on from here, and because of time constraints. But clearly, I think the information that we want to disseminate is that we have certain screening methodologies that exist, and certain methodologies may be used for certain group of people in terms of whether income status is and whether they're in rural or urban population, and whether we can scale it or not. And there will always be ups and downs for certain screening methodologies. Clearly, If you look at the worldwide data, uh, both clinical breast examination and mammography have been shown to be gold standards. And but what has been gold standard for the past 20 years may change going further. And Dr. Gita already mentioned that more data and more validation would be required for the newer technologies. But I think we have to look forward and hope that we can scale up other newer technologies so that we can capture the vast majority of our women. But barring the methodologies aside, Ms. Nirja, can you talk about why are our women not coming forward for screening? What is the stigma associated both with breast cancer as well as the screening for breast cancer? Because methodologies may be there, but if the women do not want it or they don't have the education or they feel stigmatized, all of that is going to fail for us. Ms. Nirja.
Last but not the least, yes, Vijay. So I can just talk about my experience. I have gone through breast cancer twice. It's lovely that whatever aspect you've brought up, somehow or the other, it concerns me because, uh, A, both times I it was detected by me and myself. I felt a lump. I rang up the hospital and I said, I want a doctor. They said, sorry, none not available. I said, I don't care. I'm coming. You have someone there. I got it tested. And this was when I was 44 years old. And yes, it was in pretty much between the third and the fourth stage. I was told, by the way, that you have 25% chances of survival, and not in India. You need to go to France or to America because that's where your treatment is. And well, so what I'm going to tell you is hard facts about what I've been through. Self awareness is very important. And both times, when I was 44, I felt the lump. When I was 55, I wanted to sleep in my front, and I again felt the lump. And this was, of course, pretty much before the amount of emphasis that is given for self breast examination. Secondly, I am an ambassador of many groups. One of them is the India Turns Pink. So what they have done is, and what we have done is that by 2030, we choose or we're working towards making Tamil Nadu a place where it is going to be cancer free. So, how did they start off? Schools and colleges, yes. And in every school, so we started with the urban areas and landed into the rural areas. Every school and university, college has been in the senior classes. Uh, attempted to go and give awareness. And in each institute, 50 warriors are chosen. These 50 people per institute are taught self breast examination, and then they are let loose into the world. So we are doing a lot. Now, I am very much for it because I believe in self breast examination being the. Now, the more awareness spreads, the more that a stigma about not attempting to talk about one's body parts. In India, we do have this feeling of, oh, we can't talk about certain attributes or aspects of our feminine form. And I think when we go into schools and colleges and into the villages, grassroots with mobile units, taking everything with us, we are spreading this information about the breast and we're removing the stigma. Now, the stigma is not only Vijay as far as self breast examination is concerned. There is a lot that needs to go into awareness. So once the each and every person is aware of it, and I'm so glad one of you, Devika, brought up the fact about men. Of course. Now I do have a 4-minute video on Nirja Malik official YouTube channel, and it has gone through doctors who have felt that that is a beautiful one, very, very scientifically proved. Please, I hope that a lot of women can go to it, and I hope that the men behind the women actually propose to get their mothers, aunts, grannies, daughters, sisters into the act. It's wonderful because a woman tends to keep herself on the back burner, and if something is wrong with anyone, she'll go rushing for them, not for herself. Not today, it'll go away. Maybe another day, I don't have the time. So we've done away with that. So once the examination is done, now you talking about stigma, you're absolutely right, because I have been counseling patients, cancer patients, for the last 24 years, since I was diagnosed in 98 first and then 2004. And what have I come across? Lack of awareness, yes. Lack of education, yes. And also the fact that a lot of women who come from villages and from other places feel that cancer is infectious, that cancer is contagious. I remember a woman who came to me. She had a 4-year-old son, she had a 6-month baby, and it was the breastfeeding that made her realize that something was wrong with her because she was in excruciating pain. And the minute she was diagnosed with breast cancer, she stopped touching her husband, her son, and the newborn child.
Oh my
And
God.
she felt that only her mother and father, who she felt comfortable with, were capable of handling her, because she felt in her heart of hearts that she didn't want to pass it on to the husband or the children. So we need to not only spread awareness of self examination, of different kinds of ways of getting about it, but also the fact that cancer, last of all, is not infectious or contagious. So I've had to work with a lot of people on a lot of issues regarding the breast being part of a woman, and the fact that this knowledge of, oh my God, I don't want to pass it on. So these are the things that come in the way of even people coming forward for their self-examination. I think what we're doing in Tamil Nadu is pretty good, and I hope that there will be a time when this awareness is automatic. Education, schools, colleges, clubs, women's organizations, everything. We need to talk about it. We need to tell people that, listen, it's not as bad as it is. Treat cancer as only a word, nothing more. And with the advancement of science, all you doctors, wonderful people here, know that diagnostics has improved fantastically, treatment has improved fantastically. And I'm so glad that newer methods are coming up. And it is thanks to you doctors, thanks to the policymakers, thanks to everyone that we are reaching from a no space to a hell of a good space. So thank you very much, Voice of Healthcare, to give us this opportunity to have a session together and to spread the word. Thank you, Vijay. And I hope that I've spoken straight from the heart and tell you that everything is feasible. We can do it. We will do it. And breast cancer out.
Thank you, Mr. Ija. That was very very inspiring, and I think it is quite commendable of what you're trying to achieve in Tamil Nadu, and I hope we could replicate that across the country. I mean, I think one of the questions that obviously that come up is that can this become a standard school curriculum? Talking about cancer prevention, talking about cell breast examination, and not like is it not just for women but even for the men. So, Miss Devika, can you highlight on this fact that can this become a part of school curriculum, or how can we incorporate this or take this forward?
You know, it is utmost important to include themes related to health, including breast health and breast self examination, as part of the school curriculum. But as Nirja said, there is so much stigma attached to the breast or the female form. I saw this when I was going to not schools but colleges. I mean, they would be giggling, laughing. They would be shy. Women wouldn't come forward. So I think the first thing we have to do it when they know that it's part of a regular curriculum. It's another subject in school or in college. It will be treated more normally. I think the lifetime risks would come down. Women, first of all, breast self-examination should become part of every educational system. I, as a breast cancer survivor, had not ever done a breast cancer self check till I discovered it, and that was also just by a mammogram. Even though I'd been educated, traveled around the world, nobody talked about cancer screening. When I discovered my cancer in 2000, it came as a shock to me. The first time I saw it on a mammogram, and I even asked my doctor who did the screening as to what do I do with this mammogram, and she said, go to an oncologist. I didn't even know who an oncologist was. I mean, somebody as educated decide. That really hit me. That was one of the reasons. Once I had my treatment, I set up the Women's Cancer Initiative in partnership with Tata Memorial Hospital, mainly to start. One of the main objectives was to create awareness about early detection, how important it was to catch a cancer early. In my case, because it was caught early, it was the start, it was treatable. And today, 22 years later, I'm here. I go out telling people that, it can happen to anybody. There is no stigma attached. That's the main thing. As Nirja also pointed out, we have women, even educated, who still believe that they can pass it on to family members, that they cannot breastfeed ever again. So the educational program, and therefore the system of education, which means the government, has to come into play. I mean, we have to set up forums. It's wonderful that we are sitting here and discussing this, but we know that breast cancer is 1 in 22 women in her lifetime in India can get a breast cancer. I mean, that's not a good figure. It may not be as much as the West is, but it is still an alarming figure, and it's growing. We know that more than any other cancer, breast cancer in India is galloping. What are we doing as a government? I mean, we have programs for polio, we have programs for everything. Why are we not focusing, and why are we not setting up forums? Why are we not addressing this? When we talk about self breast examination, when we talk about training health workers, there are no costs involved. We're not talking about setting up mammogram centers all over. We're talking about, and I know that at Tata Hospital, they are training health workers to go into the slums. Tata had done a study, took 150,000 women from the slums of Mumbai. They did a whole series of checks with them, and they discovered that actually the incidence of cancer are very, very low because and can be picked up very early. This was published in a British health journal. They did not pick it up late, and therefore it was curable. I mean, a simple test with a self breast examination can give you such wonderful results. Why are we not pushing to make it mandatory in our educational systems?
Devika, I'd like to add something here. I have a very dear friend who I've known for the last 35 years called Khushbu. She's a well known actress, as everyone knows. And what amazed me was that when she turned 35, she gave me a call and she said, Neerja, I'm turning 35 and I want to gift myself something. I said, what? At that time, I had already started the Apollo Cancer Support Group. And I said, what? And she said, I want to gift myself a mammogram. So every 2 years, from the age of 35, she has been regularly doing it. And I use it as a great point because we are in Tamil Nadu, we look up to, we worship uh, actors, actresses, and I always throw this example that listen, she can do it, so must you. Fantastic. So I think we should just ease into things. Devika, that's wonderful what you spoke. We just need to ease into things with a kind of yes. It's not abnormal. Nothing wrong with your breast. And by the way, I have fed my twins for 15 months. So there's so many things that are, is it a myth? Is it not? In my family, in 3 generations, we have 40 cases of cancer. And I know that some of us have gone in for genetic, screening, and some have not. Now, when this Jolie, Angelina Jolie, went in and removed her breasts and so on and so forth, all my daughter's classmates got after her. And they said, you got to do something about it. Your mother's gone through it. And guess what? I sat back and my daughter said, Mom, I have to get this done. I said, okay. I spoke to 3, 4 doctors and I did understand that, yes, BRCA1, BRCA2, etc. You can get to know about them. But please understand, one doctor told me there are 25 genes. So even if you get to know about these two, what about the rest? But I did not say either this or that. I gave my daughter whatever information I had. I gave her the names and telephone numbers of the Adyar Cancer Hospital where they do genetic screening in Chennai. That's where I live. And I gave her the names of doctors and numbers. She got to find out herself. See, I believe, and I can only talk from the heart of what I have done, what I have experienced, what I have believed. I believe that in 1981, when two cousins and I met in America, after years, we chatted till 4, and then I said, I wonder who next. Now, what do you think I did? Don't we say nowadays that whatever we put into the universe is presented to us on a platter? What do you think happened? Out of all the cousins I have, I was diagnosed in 98. My older cousin was diagnosed in 2001. And the third out of the three of us, she was diagnosed in 2008. She had breast cancer in both her breasts and different cancers. So she needed different chemotherapies to affect her. So I really do need to say that when we go into this thing about, okay, genetic testing, okay, now what? Now I'm so hassled. Now I'm so traumatized. What should I do? How should, you know what? Step back. Please step back and don't put yourself into all this. Of course, I'm the first one to say that if your doctor suggests you got to get your genetic screening done, please. God is doc. Doc is God. That's how I have existed for 24 years. And inshallah, there'll be many more to come. Get your screening done, but don't get agitated, don't get traumatized, don't get hassled. Go with the flow. Don't think about it. Don't invite it. What did the three of us do? Ah bel mujhe maar. Set it into the universe that okay, I wonder who next. Well, sweetie, you ask for it. So that is my view of looking at it, and I am free of all those thoughts that can pull me down if I concentrate on genetic screening, and it's coming straight from the heart. Please, that was my viewpoint.
Thank you, Mr. Jha. I mean, I think it's fantastic that you brought out the issue about genetic screening. But I think one word of caution, and I'm sure most of the people that I would agree that I don't think anybody should just walk in and asking for a genetic screen. It's they should all go through a genetic counselor or a doctor's prescription rather than just volunteer and say, "Well, please test my blood for genetic screening," because it could be dangerous both physically as well as psychologically in terms of not having the right information, and information is everything as far as genetic testing is concerned. And we can get Dr. Vani to chip in here to talk to us a little bit about what genetic testings are available for breast cancer, who should do it, and why is it so important. Dr.
Perfect.
Vani.
Yeah, sure. Nirza, you brought in very beautifully. You put in personal experience there and made it much easier for me to bring up the issue of who should be doing genetic testing, who should be worrying about it, and should everyone want to worry about it. So let's just start with some figures and numbers. So essentially, if you see breast cancer, there's only a 5 to 10% incidence of genetic cancers when you look at breast cancer. 90% of them are going to be non-genetic related. So you see, you don't see 90% of them needing to even do a genetic testing. But then how do you identify these women who need to have a genetic testing? Younger the woman is, that means below 35 years of age, obviously the genetic risk is much higher. But that does not now take out the fact that should a 60-year-old also undergo a genetic testing? The year that we look at the cutoff age at which we do genetic testing has been slowly increasing from 35 to 40 to 45 to 50, and now it is even at 60. But then there is another thing that plays in over here, the number of people in the family who have breast cancer. So if there are two first degree relatives who have breast cancer, or there is a younger than 35-year-old relative who has breast cancer, or there is a breast and ovarian cancer running in the family, or in the first or second degree relative. Second degree would be cousins or maternal aunts, and this is majority of them coming from the mother side. But then that does not negate possibility of a breast cancer in the paternal side also being because of genetic mutations. A male breast cancer in the family itself makes it higher risk for a genetic mutation being there, and these are the kind of families who need to test for the genetic mutations. The next comes, of course, breast ovarian syndrome, but then there are a lot many other cancers also related with breast cancer, and they form syndromes. So it's not just breast and ovarian cancer; they can be even gastric cancer, pancreatic cancer, thyroid cancers, which can be connected even with breast cancer. So you see, there is a whole lot of range of tumors and cancers in the family which can be coming up, and which kind of makes you aware of the fact that look, there is a possibility of a genetic element here for cancer having developed in somebody who is very young. We know that age is an important risk factor, and higher the age, getting a breast cancer may not be really related to a genetic risk. But I would then put in one more thing. So if somebody has a genetic mutation and has crossed the age of 45, has not developed breast cancer at all, the chances that it's a genetic mutation causing cancer in them later on, say when they are 60 or 65, is going to be much less. So there are certain mutations which make you at risk for cancer even at a higher age. Next comes in the fact that if there is a genetic mutation, should one follow what Angelina Jolie did? Would doing a bilateral mastectomy and an oophorectomy, removing the ovaries, removing the breast, is that going to make you, bring you down to a very low risk of developing cancer? Not really, because the kind of surgery that's offered on prophylactic basis does leave behind certain tissues. Nipple is left behind, tissue behind the nipple is left behind. Sometimes the axillary tail, as we call, part of the breast gets left behind. So there is still a small risk of breast cancer coming even after a prophylactic mastectomy. So as you see, there is a whole lot of things that one has to keep in mind. The genetic risk is primarily in a younger woman and a younger age group.
Thank you, Dr. Vani. That was a good information on who should be doing the genetic testing and how to approach it. And the fact that just because you have a mutation does not mean you will definitely get cancer, and vice versa is also true. So I think it should be done in conjunction with speaking to the professionals who deal with the oncologists who deal with breast cancers or a genetic counselor who can give you the right information rather than take random decisions, because it can have significant social implications going forward, both for the person involved and the family and the extended family and their children and vice versa. So I
Right.
think
Let
we
me
have
add one more point. Yeah, one last point on this. It's that if somebody has already developed a breast cancer and then goes for a genetic test and finds out that look, there is a mutation, what happens with the contralateral breast or the opposite breast? Should one have a contralateral mastectomy in that case? Because a lot of women are afraid to have breast conservation when they have a genetic mutation. So breast conservation per se in a genetic mutation, in presence of genetic mutation, is safe, and doing a contralateral removal of the breast just because you have a mutation is not really going to be protective because you've already developed cancer decides your outcome. So, hence, the decision to do a bilateral mastectomy after developing cancer is also something that needs to be really discussed with the counselor, with your clinician, with your surgeon, and then take that decision. There is nothing that gives you the verdict that you must have all organs removed just because you have a mutation. And like you likely pointed out, presence of mutation does not confirm you're going to get cancer.
yeah,
Uh,
absolutely. And
Vijay, I would like to add a little something here. So, when I was in Chennai, I was advised a mastectomy. Then I came to Bombay and I got my treatment done here because my family, my support system is here. And when the doctor said, I'm going to do a lumpectomy, Vijay, I cannot tell you how traumatized I was at that moment. I actually went down on my knees and I told the guy, I said, please do me a mastectomy. And he said, why? And I said, because, there's a chance of it coming back in the same breast and blah, blah, blah. And I'm so glad he cleared my thinking because I have helped a lot of patients not go in for unnecessary mastectomy. The way I look at it is if the doctor doesn't give you a choice and doesn't say that, look, it's elective, you decide, do you want a lumpectomy or do you want a mastectomy? That means that there is scope. And why would he come to such a decision? Because there is an ample margin. It is away from the chest wall, and whatever he feels, which quadrant it is in it. And only once, when this was cleared to me, did I go ahead with a lumpectomy. Now, I could have gone in for a mastectomy. It would have been a larger wound. I mean, so many hassles. It doesn't hassle me. The second time it came up, I didn't even think about it. I just asked him one question. Is the lump removable without the mastectomy? Can we just do a lump? Yes. So I had a port put in both times. It was very easily done. The lumpectomy. I would just like to say one thing here, that I've been in this space for 24 years, and I think that a lot has to do with the mind. A lot has to do with hope, courage, faith, belief, love, etc. And this is something that I would tell everyone, that please consider cancer as only a word, nothing more. Think of your treatment as only a short detour to get you to the point where you are already. The goal is set, you're going there. Sure, short detour, you'll be there. And third, last of all, Vijay, and all of you, and all who are looking in, laughter is the best medicine. So please have all these qualities, these characteristics, and the faith, and just do it. Thank
Thank
you.
you very much. Thank you very much, Nirja. I think we are just over an hour now. So I think we're going to wrap up and we'll get the final statements from all our panelists just before we close. So we'll start with Dr. Geeta. Any final words for our audience who are watching us?
So I think there are several nuggets that were shared today. Please follow the clinical breast examination if it's available, self-breast examination, and please do not, shy away from using newer technologies. And I think it has to be a marriage of technologies and clinicians to actually come up with newer methods that can, change the status of India and throw breast cancer deaths away from India, like we did for polio.
Thank you. And it's really commendable what you are trying to achieve through Nirmal. Thank you very much. Ms. Devika, any final words for your audience?
Well, what I'd like to say that in many Western countries, they have national screening programs for women to undergo mammograms, but this is often leads to the increase of early breast cancer, basically mainly BCIS, and 25% overdiagnosis. Now, this is something that we must bear in mind. 3 years ago, the government of India recommended clinical breast examination by a trained health worker. However, this proposal of breast cancer screening is quite low in India, and most often screenings are opportunist. Why aren't we laying stress on the health officials in government to start a more aggressive program for screening with trained, skilled health workers? And this is something that I would, as the Women's Cancer Initiative Vice President, be happy to put a forum together. And if all of you would come forward, because this whole discussion really has proven that breast self examination, clinical examination is as good, if not sometimes even better, cost effective. You can do it at a larger scale. You can take it all the way to rural India. So let's put our heads together. Let's today come to some conclusion that we need to have a government policy addressing this so that more and more women can go under this program and lives can be saved.
Thank you. And I think all of us would be more than happy. I, for certain, would be happy to volunteer for something like this. And all of us are here for the right reasons in trying to get breast cancer incidence down as well as increase cure rates. And screening is probably the way to go forward. Dr. Sneha, any words from
Yeah.
your end?
Yes, as I have already shared with you that working on three-tier system, the not only the gynecologist but all the even the general family physicians, they should make it a habit to examine the breast, and as we have already said, the paramedics, they have to be trained, and the general public, they have to have the breast awareness, so that at least whatever is abnormal, they should be able to catch up and have access to their doctors for further investigation. So I think if you work at three-tier, all the three tiers, even when we are talking about the technological advancement, but for a resource poor country like India, I think we have to work at the grassroots level. And as Dr. Gita has already said, I fully agree with the artificial intelligence. I think when we are advancing towards the technological advances, it's definitely going to help us, and hope that breast cancer screening becomes more accessible and affordable in near future. Thank you so much for having me here.
Thank you, Dr. Sneha. Dr. Shalini, any final words from you?
Yes, I would like to mention that apart from clinical breast examination, self breast examination, we need to make our population aware of what are the risk factors for breast cancer, because the risk factors of breast cancer are like alcohol use, tobacco use, obesity, early menarche, late menopause, and also physical inactivity. So there are a lot of things which we can do ourselves and improve our metabolic health, because not only will they help us from developing cancers, but also they will also help us in getting rid of other cardiovascular diseases and diabetes. So these diseases have a common link, like cancer, cardiovascular disease, diabetes, and metabolic diseases. They have a common thread, and having to take care of one, we will be able to take care of all the others. So that is my message for everybody.
Thank you. Thank you. Very aptly put, Dr. Shalini. Prevention is always better than cure. No doubt about it. Ms. Nirja, any final statement from you for your audience?
Yes, yes, please. Shalini, that was a wonderful point you brought up because I had my twins after 12 years of marriage. Uh, the rest, I had lots of miscarriages, a stillborn in the 8th month, blah, blah. And of course, I was given Clovemid and many other things to help in, having my twins. At that point of time, which is my twins are 31, at that point of time, you go to a gynecologist and you say, I would like to have a child or children, as the case may be. They do not tell you, they never did in those days, the risk factors that all these hormones or whatever they use to help a pregnancy or to, keep the fetuses safe may, does, could lead to breast cancer. So I think so many wonderful things have come up today because of the association of ideas. So I would definitely like to say that thank you for calling this program Conquering Breast Cancer, because the person who coined the word conquering is I, me, and myself. And that was 24 years back because my father said, don't fight cancer, face it. And I'm happy to have that word in this. And secondly, I just want to remove the flag. Some people say that when I meet I'm just going to take a minute. When there is a patient with me and a surgery takes place, and I tell the patient, you know what, you're cured. Then the patient said, if that is so, why do I have to have chemotherapy and radiation? So I said, when you buy a gift for a loved one, do you just take the gift and say, here? Nah. So the gift is the surgery. The packing is the chemotherapy. And the radiation is the ribbon with which you tie it and finally present it. So if we can look at things like this, doesn't it simplify cancer, the big C, which is after all a dis-ease? Thank you very much.
Thank you, Mr. Nirja. Thank you. And Dr. Vani, any final words before we wrap up for the section? Dr. Vani, your final statements for the audience.
Yeah, so we have, I think, discussed a lot about how early detection does help you to detect cancer early and have a better chance of cure. But let me bring you to one more angle of it that never got discussed, and that is that the earlier the tumor is dissected, is detected, the smaller the tumor is, the higher the chance that you're going to have a breast conservation and much better surgery. So it's all a package that goes with it. Nirja has put it very beautifully. Everything, whether it's chemotherapy, whether it's radiation, whether it's hormone therapy, and whatever you do, earlier the cancer is detected, everything will come in small doses. And I think that's where we are all leading to. The toxicity is less, the benefits are more. And I think that's where today, I think the final concluding statement should be, let's promise ourselves that we're going to be more breast aware. Let's promise ourselves that we're not going to shy away from going to the doctor and speaking about your problem. And breast is not something, it's not a stigma. Like breast cancer is not a stigma, and we're going to have the treatment given as early as possible. So that all depends on yourself. So go ahead, be breast aware, ensure that you get a treatment early, and conquer cancer early. Thank you.
Thank you very much, Dr. Vani. It was indeed a pleasure to be with all of you and good exchange of information. But I think we're going to have to close this session because we've overshot our time by 10 minutes. So thank you all, one and all, and thank you for all supporting breast cancer awareness. Thank you.
Thank you,
Thanks a
Vijay.
lot.
Thank you,
Thank you
everyone.
very much. Thank you for